Hi, my name's Nicketti Handy. I am the Breast Surgical Oncology Fellow at St. John's Cancer Institute, working at the Margie Petersen Breast Center. This is a one-year-long fellowship after general surgery residency, so I started in August of 2023, so I'm about halfway through right now. I'll be graduating in July of 2024, and essentially this year so far has been super fun. It's all things breast. So obviously, since I'm doing breast surgery training, I'm working very closely with our two dedicated breast surgeons at St. John's. So that's Dr. Grumley, the program director, and Dr. Fancher, her partner. But I'm also working with all of the multi-disciplinary teams that are involved with breast cancer care. So that includes our medical oncology doctors, our radiation oncology doctors. I'm currently right now on a radiology imaging rotation where I'm working with our radiologists to learn how to read, interpret, and kind of properly apply breast imaging from mammograms, ultrasound, MRIs, nodal imaging, etc. But I also work with our pathologists to get a better understanding of the histopathology of our breast cancers, and even some of the kind of softer sciences. You know, we work with our social workers, we do a breast psychology rotation, we work with the genetics teams to go into the breast cancer mutations that make people higher risk screening candidates versus a new diagnosis of breast cancer, and how we follow them up and what their potential family risk factors are. We also work with the plastic surgeons. For our mastectomy reconstructions, our plastic surgeons come in and help with tissue expander placement, implant reconstruction, or free flap reconstructions. I would say one of the best benefits of being at St. John's specifically for my breast training is getting to work with Dr. Grumley and Dr. Fancher, who are both really excellent Onco-plastic breast surgeons. So Onco-plastics is when you're combining the aspects of cancer removal surgery with the plastics reconstructive surgery. And we do that all on our own as the breast surgeons, where we're both removing the breast cancer but also reconstructing the breast so that we're able to offer wider ranges of breast conserving surgery to our patients, and mastectomy isn't their only option, even for larger tumors. From that perspective, it's been everything I could ask for and more. I've gone to several of the different conferences around the country for the breast fellows, and every time I go, I meet with many other fellows from different programs, and I always come back feeling really good about my choice to come to St. John's, because I feel like I'm just getting an incredibly well-rounded and thorough education here. So in breast land alone, I couldn't be happier. We are also working with our researchers. So we have a couple clinical researchers that are dedicated to breast cancer research, and we work with them for various research projects. I'm going to be presenting a video at the upcoming American Society of Breast Surgeons meeting in April, where we go through doing reconstructive breast cancer surgery for male breast cancer patient who typically they aren't offered much with breast reconstruction compared to their female counterparts. So that's a project that we've been working on that I'm really excited to talk about up at the podium. And then we also work really closely with the other fellows from the Complex General Surgical Oncology program. So every Friday morning we have didactics that are set aside where we go through interesting cases. We talk about kind of interesting academic learning points. We all touch and share resources on various research projects that we're working on together. So it's a really collaborative atmosphere. So even though I'm the only breast fellow, I certainly don't feel like I'm the only fellow here at St. John's. There's a really satisfying and in-depth community between all the fellows. The average day-to-day here when I'm on the surgery service, for example, I'll come into work. If it's a clinic day, I get to look cute and wear real clothes, not just scrubs. And I come into the clinic and we see the patients. So typically I'll see the patients first, and then after I've seen them, kind of gotten all their information, their whole story together, and come up with my own tentative plan, that's when Dr. Grumley or Dr. Fancher will also join me in the room, and we'll sort of finesse the final details of the treatment plan for our patients. One of the things that we do at St. John's that is not ubiquitous everywhere is what we call multi-disciplinary clinic, where every time we have a new breast cancer patient, she's seeing the breast surgical oncologist, but we're also on the same day having the patient meet with our medical oncologist and our radiation oncologist. So the patient has 3 appointments with all of their oncology physicians. And then we, in the middle of that meeting, meet up with our radiology colleagues and we all talk together. So the radiologist, the radiation oncologist, the medical oncologist, and surgical oncologist, and we all go through each component of this patient's care, and we all collaboratively come up with the best approach for how to treat their breast cancer. So it saves patients from having to have a lot of medical hopscotching where they have to go from one clinic to another, potentially with days or weeks between appointments. We consolidate it all so that our patients can get seen by everyone they need to one morning all together and have a plan of action moving forward. So it just feels really collaborative and organized, which is what I would want if I was a breast cancer patient, and it's certainly what I would want for a family member or a friend of mine to get if they were a breast cancer patient. So there's room for flexibility. For example, we shuffled rotation schedules around a little bit to accommodate for various attendings when they'd be out of town. We obviously wouldn't want me to be on the medical oncology rotation when the main medical oncologist I work with wouldn't be there. But generally, every month you change rotations. So the first couple of months you're on breast surgery. We do have a research month that's dedicated to just helping get your research projects off the ground. And that's typically in the probably first quarter of the year, just so that you have enough time to sort of get organized, you've moved, you've kind of figured out the lay of the land, you've met the people you need to know, and now you're able to invest in research projects. But then month by month you change rotations. So for example, I did breast surgery, I did a research month, I did breast surgery, I did a radiology rotation, a radiation oncology rotation. I now have a couple more months of breast surgery ahead of me. I believe I have a total of 5 or 6 months of breast surgery. So about half the year is breast surgery, but the other half of the year is all the other subspecialties that are related to breast cancer care. So medical oncology, radiation oncology, radiology, pathology, genetics, plastic surgery. You generally kind of get a sense of your schedule at the beginning of the year, but it's flexible. If I was really excited about something and it was only going to be available during a certain part of the year, Dr. Grumley would certainly work with me to be able to change the rotation schedule around to best accommodate my learning interests. Clinical research is very well supported with the breast cancer crew. So, once a week we have a breast cancer meeting, basically, where we talk about our various research projects and we just check in with where we're at with various research projects. We'll have little brainstorming sessions if we have any ideas of future projects. And, if you ever have a suggestion, people talk about it. They talk about how we would potentially put that into effect, or maybe there's someone on the research team that already knows a bit about that topic and says, actually, that was covered, and here's some research for that you can do for a lit review. So it is very organized and it's well supported. You have a very collegial relationship with the other researchers. It's not competitive where people are trying to snatch projects from one another. People are eager to collaborate and kind of use our different interests and talents to create well-rounded research projects where we could potentially investigate a clinical question. For example, we have noticed that a lot of our patients are reluctant to take endocrine therapy. And that's a really big part of cancer care. And so we're investigating why. Why are they reluctant? And it turns out, just by talking with our patients, a lot of them have worries about potential cognitive decline associated with their body being deprived of estrogen. So, there have been substantial research efforts into the neuroprotective effects of estrogen. And now we're going to try and take some of that research and potentially apply it to our breast cancer patients and see, is there an increased risk of dementia, for example, in someone who has a history of taking endocrine therapy? Because we think that'd be helpful information for our patients to know, and then we can help kind of guide their treatment moving forward based on the answers we may discover by investigating that further. Breast cancer care has been one of the leading groups, like a leading disease, I would say, for encouraging and perhaps requiring multi-disciplinary efforts for collaborative care. So every week we have a tumor board, so every Monday morning, And the breast fellow is in charge of leading the tumor board. So the week before, I get all the various information about the patients we're presenting. I get our slides from our radiologists about the relevant imaging that we want to include. We loop our pathologists in, and they're able to showcase the pathology slides to point out relevant findings. And then every Monday we go through and we talk about the nitty-gritty details of each patient with, a cancer diagnosis, either pre or post-surgical treatment. And we talk about what their next plans are, whether it's neoadjuvant therapy, what type of surgery we should recommend, do they need adjuvant therapy? Loop back with our patients and say, we've all talked about you and we've all used our expert opinions and literature awareness to give you a tailored cancer plan. St. John's is a little gem in the city of LA. It feels cozy, if I can say that. I feel like you develop really close working relationships with not only the attending surgeons you work with, but your medical colleagues, your radiology colleagues, your pathology. Like, I know our pathologists, the people that are reading our slides and giving us our breast cancer diagnoses, as well as the nurses and social workers and support staff in the breast clinic. And so, it's not uncommon for us to go out and do a happy hour after work on a Friday. And I feel like it's just a special place where you know each other, you're working really close to each other, like physically in close proximity. And so if you have a patient that you want to be seen by your radiation oncology colleague, it's not a schedule and they get seen weeks later. I'm able to go just down the hall and tap their shoulder and say, hey, do you mind taking a look at this patient? Is this someone you think you'd be able to see relatively soon? And so we just work really well with being able to accommodate requests from one another and having a really collaborative, close-knit environment. And so again, it ends up being really good for patient care, but also really good from a learner's perspective, because there are times when I'll be taking care of a clinic patient in my surgical clinic, and some part about their chemotherapy regimen or their radiation therapy regimen isn't quite making sense to me, and I get to just head down the hallway and knock on the door of Dr. Petty or Dr. Woolman and say, hey, can you help me learn this so I can understand it better? And I have done that. I plan to continue doing that. And even extending beyond fellowship, I feel like I've developed relationships with the faculty of many different subspecialties here, that if I have a question about a patient of mine when I'm in practice, potentially years from now, I would feel comfortable reaching out to them, asking for guidance or another opinion. So I just think that that's not necessarily a given when you're in a really big setting where maybe you just don't know each other very well. We get to know each other all really well. And so they know my strengths and they also know my weaknesses and how to help me overcome them. So I feel like it's a really nurturing environment from a learning perspective. That's the main goal of surgical training, right? Is you want to be able to be a surgeon who can operate on your own and be safe and, talented for your patient's benefit. So I definitely feel like I get that experience here. A typical case with Dr. Fancher or Dr. Grumley is often involving onco-plastic surgery, where we're not only taking out the cancer and doing the reconstruction on the cancer side, but we're also doing a reconstructive operation on the non-cancer breast so that the patient feels balanced and symmetrical at the end. And so as a result, I have the opportunity to essentially be operating on my own on one side, while my attending is across the table operating on the other breast. So both Dr. Grumley and Dr. Fancher have been really good about making sure that I'm on primarily the cancer side, so that I can really finesse my skills and confidence and competence with removing the cancer and then, removing any axillary lymph nodes that are indicated, as well as working on the breast reconstruction. And it's really great because oftentimes I feel like I am operating on my own, but of course, if I ever need guidance, they're just a foot away on the other side of the table. And so I do feel really confident being able to go into practice after this fellowship. And I've currently in the interviewing stage for job searching, and that's a question that I've been asked. They say, well, how comfortable would you feel operating on your own right now versus needing any sort of kind of faculty proctor when you're getting your practice off the ground? And I I'd be fine going off on my own. And even with some of the more complex plastic surgery components of our reconstructions, you know, a lot of breast surgeons bring in a plastic surgery colleague to help with the breast reduction or the breast lift. And that's something that I feel I've learned the skills to do those surgeries on my own at this point. Early in residency, I learned that I really liked taking care of cancer patients. And once I learned a little bit more about breast cancer care and the Onco-plastics portion of breast cancer care, I got really excited about becoming a breast surgeon. Again, I love the kind of artistic component of reconstructing a breast. There's a lot of kind of just aesthetic intuition you have to use when making those intraoperative surgical decisions and surgical planning. Taking care of cancer patients is rewarding. You are invested in them, you see them, so you get continuity of care, you follow up with them, oftentimes you get to know their family as well, and I like that rewarding patient-doctor relationship. I guess what's kind of funny is I did overlap with Dr. Grumley my intern year, so my very first year of surgical residency up in Seattle. She used to be working at Virginia Mason Medical Center where I did my residency training, and we did overlap for that 1 year. So when I learned that she had made a Breast Surgical Oncology Fellowship, just having known her personality from residency, I knew that it was going to be organized and high performing. When I interviewed with her program here, it seemed like a really good fit. Well, I'll be graduating at the very end of July in 2024, so I'll have a breast surgical oncology diploma to add to my collection. But I think it's worth giving a little plug for how fun it is to live in LA, specifically Santa Monica, for your 1 year of breast training. It's beautiful and sunny most days, and I love roller skating, so I have joined a roller skating gang. When I first moved to LA, there's a group called the LA Skate Honeys, and they arrange various little meetups for roller skating gangs to go off. And so that's been a fun thing to do on a Thursday night, for example, after you get out of a long day of operating. You get to go meet up with the roller skating gang by the beach and go ride along Santa Monica Pier. So there's a lot of things to do around town. The art museum scene is really good. There's bike paths along the beach. I can ride my bike up to Venice Beach and meet up with a friend for dinner or drinks. And then living in LA, it's a place that a lot of your friends and family like to come through and visit. So I've actually had a lot of visitors while I've been here, and that's been a really fun adventure as well.